few housekeeping items before we get started. Maybe if I can find my document. Here we go. Links to the pre-test, post-test, and evaluation were included in an email that I'd sent out earlier. And I will also put those links in the chat box. Please complete the pre-test if you haven't done so already. Remember to mute your audio when you're not speaking. And then if you could, Ashley, not you, because it looks like you're driving in a car, so please don't type in the chat box, but please type your name, credentials, email, and facility name in the chat box. It's just kind of another way that we can kind of keep track of you to be sure you get the credits, whether they're CME credits or social work credits. That just helps us. And as part of participation in this ECHO, we ask to have your cameras turned on in order to build a more engaging community of practice. Maybe not so much during the didactic presentation when Rebecca is sharing her slides, but in the Q&A portion, if you do have a question, please show us your face if you're going to unmute yourself. And if you do have a question and you want to ask a question, please unmute and ask the question, or if you don't want to interrupt, you can utilize the chat feature to ask the question, and I will be sure that Rebecca is made aware of those questions. And today we have Rebecca Quinn. She's a program director for the Center for Rural Health at the University of North Dakota School of Medicine and Health Sciences here in Grand Forks. She manages the North Dakota Brain Injury Network and the State Epidemiological Outcomes Work Group project. Her past experience includes working in various settings, primarily in the healthcare field. She has served as an adjunct professor in the social work department at UND, where she taught courses on gerontology and substance abuse. Rebecca is a licensed social worker and obtained her master's of social work degree from the University of Texas at Arlington in May 2000, and her Bachelor of Arts degree from Texas A&M in 1997. And I would imagine today you wish you were still in Texas, Rebecca. But without any further ado, I will go ahead and let you have the floor, and I will put those links in the chat box right now.
Okay, thank you. Thank you, everybody. So yeah, I would prefer to be in Texas right now than here. I think there are a lot of places I'd prefer to be than here right now. Although more importantly, I did spend the first like 7 years of my life in Hawaii, and I would be okay with going back there now as well. So today, going to talk about traumatic brain injury in older adults. So this was something that Gunjan had reached out to me about as a potential topic, and I said I would be more than happy to provide that. One of the things that I will preface this with saying is today we're really going to talk about newly acquired brain injuries in older adults, which is very different population than those that have had earlier in lifetime sustained injuries and then are now aging with those. However, don't be remiss. I have talked with Gunjan and Julie about doing a session on those aging with an already acquired brain injury and risk factors and all of that in an upcoming session. So there's your little teaser for future. But so today, really talking about traumatic brain injuries and those newly acquired injuries in older adults. One of the things that I always, in starting out any talk on brain injury, really start out in talking about what is the definition of brain injury and what, where are we at with it. It is a little confusing. Basically, an acquired brain injury is any injury or damage to the brain that occurs after birth, but before you get into your degenerative disorders. So the after birth part means it doesn't include anything congenital or genetic. So that would be like birth injuries, fetal alcohol, any perinatal illness that the mother might have that impacts the baby, those things. So that is in a separate category. And then your degenerative disorders like Alzheimer's, MS, Parkinson's, those are really in a separate because they're your degenerative. So any, damage that they're causing to the brain is in a separate category. So really we're talking about that middle category of acquired brain injury. Now, within acquired brain injury, you then have a breakdown in the fact that traumatic brain injury, which is TBI, and that's anything that's occurring from external force. So really what we think of when we think of brain injury, it's that something that happens to the brain, but from external force. And then you have the other types of acquired brain injuries that are also causing damage to the brain and fall into the injury category. I think sometimes that injury terminology is misleading because people really do think that it is that traumatic injury. You know, we think of injuries as a broken bone, injuries as that external, that force. But really, from definition, these other causes are also considered injuries. So oxygen deprivation, infectious disease, chemical or substance exposure, a stroke or tumor, all of those are also causing injuries to the brain. Today, mainly, we're going to be talking about traumatic brain injury, but I will say that both mechanisms of brain injury can result in chronic disability. Many of them, they can get worse with age and are things that have kind of a different management within the older adult population. So, but just that overview of what definition we're really talking about. So as far as from just quick facts and figures, TBI in America, it is estimated that 2.8 million people will sustain a TBI annually in the United States. Of them, roughly about 50,000 will die. And about 282,000 are hospitalized, and then 2.5 million, so nearly 90% are treated and released from emergency departments. So majority of the brain injuries, an overwhelming majority, are those that are treated and released from emergency departments and have more what's kind of considered that more mild injury. So one of the things that's kind of shocking and why having this session with you guys is the rates by age group. Yes, the number one population for sustaining brain injuries in the United States is your 15 to 24-year-olds range. So that is your number one. You can see by this that they overwhelmingly have a high rate of emergency room visits, but also a high rate of the total brain injuries sustained within that population. However, the second highest category is over 65. And one thing that you can see by this is that even the over 65 category does have a much higher, is the second highest category of sustaining brain injury, but they also have a higher uptick in hospitalizations and deaths than other categories. So you can see that the over 65 category has a higher level of hospitalization and deaths from brain injuries than the 15 to 24 category. So even though they are number one or number two in total overall, they do have a higher level of the hospitalization and deaths. So one of the things is, but despite this high incidence, older adults may be less likely to seek medical attention for TBI and are also less likely to be accurately diagnosed even when medical attention is sought. So that's kind of one of the things, this is the root of what we're talking about today, is why is that? Why do we have this less likely to seek medical attention and less likely to have an accurate diagnosis, even knowing that there is this high incidence number? So again, back to facts and figures, more than 80,000 of the emergency department's visits are for those over the age of 65. 75% of those do require hospitalization, and those 75 and older do have the highest rates of hospitalization and death. So one of the things that does change is your cause by age group. This you can see the kind of red smile in this graph is your falls. So falls is the leading cause of brain injury amongst your 0 to 4 category. And then really kind of nosedives and less likely to have a brain injury from falls until it starts upticking again after the age of 45, and then has a big upswing after 65. So really falls is the highest cause of brain injuries across all age groups, but within older adults it is the primary cause. Other causes are motor vehicle crashes, struck by against is really a lot of your sports injuries are what fall into that category. So you can see that that's a very high within your, 5 to 25-year-old range, and then that starts to drop off as well, and then assault. But so by the time really getting to over 65 and older, we really are talking about older adult falls, and falls being a primary cause of brain injuries. One of the things that that really has been a recent kind of on the rise is that unfortunately deaths from fall related TBIs are on the rise. It's one of those things that we would like to believe that our deaths are on headed downward, and that we're able to be providing better medical care and interventions. But unfortunately, deaths from falls are on the rise. You can see by this graph that they are substantially kind of upticking. And one of the things that's particularly concerning for those of us here in North Dakota is the most notable increases of falls related deaths were observed in those over the age of 75. Just concerning because North Dakota, we have a substantial number of over 75 in our population, and persons living in rural communities, something that we have quite a bit of here in North Dakota. So definitely needing to be aware that deaths from fall-related TBIs are on the rise. And a key component of that, as we'll talk about later, is that prevention factor. So again, as I said, one of the reasons talking about this is why is this kind of this hidden epidemic? Why is it that we know that there's such a wide, a large population within this age category having sustaining brain injuries, being the second largest age category, but really not that much information out there about it. It's not really seen. One is that the injury is often overlooked. One, it's either seen as no big deal, treatment's not sought, it's not seen as, something that really needs that, or it's more overshadowed by acute issues. So if an individual has a fall, really, when you hear about an older adult falling, the first thing that comes to mind is broken bones. I had an individual that just this week was telling me that their grandmother had a fall and broke her collarbone. And that was really the big focus, was the broken bone. And they were happy that it was a collarbone, not, a worse bone, and something that maybe would have a longer healing time. And they, but the head wasn't mentioned at all. So I think that happens a lot, is that for older adults that do have a fall, there really is seen that there's either the head injury part is really seen as not a big deal. Yes, they bumped their head, but not a big deal, or it's overshadowed. The other piece is that the symptoms of a brain injury, after the individual sustains it, is really seen as normal decline. It falls in with normal kind of aging behaviors, and it's really difficult to discern what might be caused by a fall or a head injury versus the aging components. And a lack of awareness. Over the last 15 years, there's been a kind of huge upsurge in awareness around brain injuries, particularly related to like student athletes and, athletics, and related to, veterans and those populations. But there really hasn't been much awareness around the idea that older adults are one of the primary categories. And so it really is seen as, TBI concussion is only for the young, and not seen as a potential risk factor or something to be on the lookout for. Now, unfortunately, there are some risk factors that are part of aging that really do make individuals in the older adult category at a higher risk of brain injury and a higher risk of falls, and that being part of why that they make up that second highest category. One of the things that is a big risk factor is that because of the aging process, individuals can have a substantial injury from a very low force fall. So there's not the same mechanisms and same involvement in how a brain injury happens when you're dealing with an older adult versus somebody younger. And so a lot of our understanding of, oh, I just bumped my head, it's not a, it's not a big deal, it's not a substantial injury, is not necessarily applicable for older adults. And so older adults, you can have a low force fall or a low force blow to the head that can lead to substantial injury. So that really does make a risk factor there. And then again, in elderly falls, once an individual has had a fall, they are 50% of trauma, have a 50% risk of a repeat. So really that once somebody's had that a fall and a traumatic injury, they're at risk of having that repeat. And then just, things related to, and also age 65 are at greater risk of being hit by a car as a pedestrian than our children. Many older adults can't navigate crossing, those pieces that really make things at risk, things related to fall safety, so lower body weakness, foot problems, any type of neuropathy or chronic pain, cognitive decline. So somebody being less aware of their surroundings, less aware of risk factors and how to protect themselves. A vitamin D deficiency, making an individual more at risk of falls and risk of having an injury if they do have a fall. Many medications have, sedating effect or dizzying effect. Blood pressure medications, blood thinners are particularly concerning regarding falls. We'll talk about in a bit related to bleeding. Any type of vision problems and really being able to manage vision and, having vision deficits leading to that risk of fall. And then intracranial changes. So particularly age atrophy in the brain. So one of the things with age atrophy is as we get older, there are structural changes in the brain and the brain kind of begins to shrink. And we have more space between the brain and the skull, and as a result the veins within the brain kind of get stretched and are pulled, and so that puts somebody at risk. And so really that increase in space between the brain and the skull means that there's more room for the brain to be moving around in the skull and can have a higher increase of trauma to the brain and so that being part of why you have that higher risk of a more substantial injury from even a low level blow is because of that space, that added space within the skull. So another piece of that is puts it at higher risk of subdural hematoma. These structural changes in the brain, particularly kind of the stretching and the thinning of the veins, leads to them being more susceptible to damage and to slow bleeds. And then adding onto that blood thinning medication. So as people are on blood thinning medication, that really putting them at a risk there of also having, more bleeds from maybe a small, injury that maybe in somebody younger would not, or somebody not on blood thinners would not bleed and it would clot quickly and they would be fine. But with somebody on blood thinners and older, they're at more risk of a subdural hematoma. And even from, as I said, that minor trauma. And one of the things that can happen with older adults, particularly if in seeking emergency department care, those pieces, is these subdural hematomas can go unnoticed. And so there is this thing called chronic subdural hematomas, where older adults may have really slow bleeds within their brain, that it's not as much of the immediate reaction after head injury as you might have with somebody younger that has a quicker bleed, but instead it's more subtle buildup over time, and that being part of that risk. So one of the things is, so why am I telling you this? Really because the negative impact on that older brain may not become apparent right away. Definitely even minor bumps and blows should be checked out by a medical professional. really always that follow-up with medical professionals. And then one of the things that's important for any medical professionals or providers working with individuals, older adults with brain injury, to understand is that all of the TBI clinical measures that are in place, things like the Glasgow Coma Scale or the Ranchos Los Amigos Scale, those pieces, none of those have been shown, reliability and validated within the older adult population. Almost all of the research with those has really used 65 as their exclusionary cutoff in, validating these tools. And so one of the things that they really have started to notice, and with this population, is the need for validating those tools and even adopting measures specifically for the older adult population regarding brain injury. One of the things that are difficult around that is that when you are things like the Glasgow Coma Scale or the Ranchos Los Amigos, some other concussion batteries, those are based around, a younger population's cognition, younger population's needs. And so they really, things related to an older adult's cognitive decline, possible vision deficits, those deficits that come along with aging can skew the results of those and either make it seem like the person has less of an injury, so the injury might be overlooked as said, oh, well, yes, they scored bad on that, but that's because their vision's bad. That's because, that. Or it may mean that the injury is seen as more severe than it is because that the individual scored less, but really it's related to how the reliability of that test with them. So as part of that, that needing to seek medical care, even for minor blows to the head, definitely scans. So whether it be CT scans or MRI scans are recommended within the older adult population. That is very different than the pediatric population. The pediatric population, they now really do not recommend routine scans when you're having, a concussion, minor blows, because they're really not seen as, relevant or necessary within the medical assessment and treatment. However, with the older adults, really recommended to have that scan because of things related to the high risk of subdural hematoma and those pieces, and the changes in that assessment piece as far as doing a clinical assessment with older adults around brain injury. And so important to do that ongoing monitoring and assessment. So if you are working with somebody that you do suspect has a brain injury, or family members, kind of clues, particularly a low-grade headache that won't go away, having more trouble than usual remembering things, paying attention or concentrating, becoming more difficult with organizing daily tasks, blurred vision or eyes that easily tire out, ringing in the ear, slowness in thinking, speaking, getting lost or easily confused, feeling tired all the time, lack of energy, change in sleep pattern, loss of balance, feeling lightheaded or dizzy, increased sensitivity to lights, sounds, distractions. One of the things that's difficult is this whole list, having worked with the older adult population, all of these could be caused by any number of things, including being older. So that's why it really is important to kind of pay attention and to think when there is that sudden change. And having those caregivers that are engaged in somebody's life and tracking on these things to be able to know, has this been a gradual shift that you might see? If somebody's gradually has been getting lost or easily confused, that might be, one. But if they had a fall and then seem to, have a change in this behavior, then that be something that, would need to be evaluated. So obviously any of these clues over the last, 2 slides are things that should be evaluated, whether they've had a fall or not. If you as a professional are working with somebody or have, family members or caregivers that mention these things, then they are things that should be evaluated. Because whether it is part of that normal aging cognitive decline, that should be evaluated for, is there, potential dementia or, those pieces, changes in cognition, or is there that potential of brain injury? But really wanting to kind of try to remember and keep track of when they have had a fall, if there is changes in these things. So again, now looking at outcome, because one of the things that I think is important when talking about brain injury with these populations is looking at your outcomes. There are some risk factors that impact outcome for brain injury. Obviously, any pre-existing medical conditions. So if somebody is already having, any medical conditions that are affecting their cognition, just their overall health, those are going to affect their outcomes. Having decreased neurochemicals in the brain affects outcomes and the brain's ability to heal. Having less cognitive reserve to pull from. So one of the things that definitely is, as individuals recover from brain injury, they really rely on their cognitive reserve to bolster things up in that recovery. And if you're already using all your cognitive reserves for normal aging, then there's less of it available. Deficits are definitely more pronounced within the aging category. And again, that atrophy making the brain more vulnerable. So, but one of the things in looking at outcomes is compared to younger adults with TBI, older adults on average undergo more in-hospital procedures, have longer acute care stay and rehabilitation stays, are more likely to require continued medical care, have a slower rate of improvement on functional measures, and worse functional outcomes and greater levels of disability, and a higher rate of discharge to a nursing home. One of the things that a set of researchers said is that for every 10 years of age, they estimate a 40 to 50% increase in the odds of a poor outcome from brain injury. So, they're at higher risk of poor cognitive outcome. It is possible that cognitive impairment predisposed the injury, and so that being components. And then the effects of medication obviously really need to be considered as part of that cognition piece. And looking at functional outcome, one of the things that they did say, so from a positive, when we talk about not being so negative, and I think this is part of this is why it is important to really determine if it is a brain injury and there is components of it that are brain injury versus the normal aging decline, is that you can have positive outcomes and they can be impacted and have that positive effect in working with that individual. So this is from the TBI model systems data. And they looked at individuals over the age of 65 who received acute inpatient rehabilitation. Almost all of them did achieve significant functional improvement. 2/3 of them were discharged to a community setting, and nearly 85% were in a community setting still 1 year later. So often, I have heard from people that said, well, she's, 72. Yes, she has a brain injury, but maybe now is just, the time for her to go into a facility, but really don't see the need for that active rehabilitation with the older adult population. But a lot of the research, and particularly the study that looked at the TBI model systems data, which is longitudinal study across all brain injuries, really shows that there is that ability for still having functional improvement and functional benefit from, acute rehabilitation, even within the older adult population. So one of the things is then, what should we be doing with this? One is screening. Really, a later in life brain injury will make an individual more vulnerable to potentially death, dementia, and an earlier in life TBI makes somebody more vulnerable to a second brain injury from a fall later in life. So it is definitely recommended that programs that serve older adults screen for history of brain injury. Screen for a history of brain injury and really monitoring and ongoing, particularly if you're providing, support services to an individual, tracking on any time there is falls or that they hit their head, so that you can make note of those in case there are those subtle changes down the way to be able to track on changes. Primary prevention, obviously addressing key risk factors, medication review, doing a functional assessment, vision screens, home fall risk assessments, balance training. One of the things that really, particularly around balance training and in-home fall risk assessments, is if a provider actually does a referral for those services, individuals are more likely to follow through than if it's just recommended, or somebody says, here's a fall, prevention program you might want to do. The stepping on program is one that is really good that we refer a lot of individuals to as far as that fall risk prevention, but really they needing to have that referral and stressing that importance of doing that primary prevention. And then secondary prevention, identifying injuries when they occur. As I said, I think that is really important, and particularly for any providers to make note of them in case, needing to refer back. Oh yeah, when was that Jane hit her head? Okay, she seems to be having more problems now. Providing appropriate care, the management of any medical comorbidities, regulation of medications, providing ongoing education for somebody around brain injury if they have sustained one, and develop safe return to activity guidelines, really guidelines on helping this individual understand when it would be safe for them to return to activities and how to best manage that. So now I have a couple case studies for us to sort of talk through. These are studies of ones that I just have worked with and pulled from there. One is a 68-year-old man in a front seat passenger in a motor vehicle crash, was transported to the emergency department with a broken nose and agitation. Treated for the broken nose and discharged to his daughter. A month later, his daughter notices that he has been complaining of headaches after watching TV, seems to get flustered and confused, and has been sleeping more. So I don't know if you guys usually do discussion around these, or...
We do kind of do some discussion. We have, if you have any kind of prompts about what you would do, to work with this person, or if you have questions, you could maybe ask them that they could unmute themselves and answer, or put in the chat, however you feel comfortable, really.
Okay. I mean, I'm comfortable either way. I guess to me, with this individual, is, because this individual was treated for the broken nose in the emergency department, but was not, really was not diagnosed, or that piece, what course of action would maybe a community-based provider, like a home health provider, or maybe somebody providing, his meals through the senior center, what is something that the community-based provider could kind of provide some direction for this individual on?
Excellent. Please do feel free to unmute yourself and respond, or go ahead and type in the chat. So we do have Dr. Geriatric actually put need to inquire about subdural hematoma.
Exactly. So thank you, Dr. Geriatric. Definitely. This is a perfect example of particularly that, chronic slow subdural hematoma, of inquiring about that. I think that as a, medical provider, I think that if this was somebody, working with them in community, really stressing that need for follow-up.
Does anybody else have any comments or questions?
I kind of have the question of, do you see, in community that this is something that, this gentleman would probably think that he needs to have follow-up on this?
And we do actually have another comment, Rebecca, in the chat. It says he needs to have a full geriatric evaluation.
Yeah, I would agree. I think definitely needs to have that full evaluation. Particularly, as I stated, really making that, the list of symptomology from, that subdural hematoma from a brain injury kind of very much overlap with aging and typical, geriatric cognitive changes. So needing to have that full evaluation to determine where are things at.
Okay.
Any other questions?
Yeah, we don't have, oh, here we go. Lack of awareness of possible head injury from ED, family patient should be addressed. Lack of awareness. You want me to repeat that maybe?
Yeah.
Okay, lack of awareness of possible head injury from ED, family and patient should be addressed.
So I think you're saying that the lack of awareness from the ED, so the ED not acknowledging it and providing that information onto the family should be addressed. I wholeheartedly agree. That's definitely one of the things that we've really been wanting to do more education around. Our Brain Injury Advisory Council actually did recently raise the wanting to even develop some materials around the idea of subdural hematoma and blood thinners, and geared towards providers on how to needing to be on the lookout for that and providing that education. So I think that the part of doing this training is really that lack of awareness of the high risk of brain injury within the older adult population, and that seeing it as kind of young. And so it is frequent for it to be missed within the emergency department. Here's an example. He had a broken nose. He did have agitation. But the reality is that a 68-year-old man in a motor vehicle crash might be agitated whether he hit his head or not. So it is easy to get missed, but needing to have that education piece there.
Yep, and we have another comment. Care coordination and ED follow-up calls with education offered would help with this. And another is sleepiness may be hypoactive delirium too.
Yes.
And also a broken nose could be associated with acute somebody say it for me.
Sinusitis.
There we go, thank you. Or broken cribriform bone with CSF leak. Dr. Jurevich is using words that I cannot pronounce today.
So yes, it could. That cerebral spinal fluid leak would be a problem and needing to have that looked at. So yeah, I mean, there's a lot potentially there.
He just apologized. Sorry about that. He said he doesn't have a microphone. I'm sorry, I can't read your big words today. Okay. We don't have anything else coming through. Do you have another case study or anything else you want to discuss, Rebecca?
So yes, another case study is a 75-year-old woman who slipped on ice. Huge issue here in North Dakota. Hit her head and lost consciousness. She regained consciousness after an hour, but remained in an altered state. Imaging confirmed a right side focal subdural hematoma, and she did undergo a craniotomy. 2 weeks after surgery, findings include impaired memory, balance issues, limited ambulation, and increased tone, that should be decreased tone in the left and upper extremities and lower extremities. So a question around this, what aftercare might this individual access?
Dr. Jurevich says geriatric assessment for sure. Carol Johnson says acute inpatient rehab.
Yeah, so I would say acute inpatient rehab, it sounds like a perfect option for this individual. Definitely, and this was an individual that there actually was a struggle on getting qualification for her to qualify for acute inpatient rehab. One of the struggles that we had, this was an individual that I actually worked with, one of the struggles was the problem was when they were inpatient at the hospital, the criteria for accessing acute inpatient rehab really had to do with the number of hours you can sustain therapy. And this was an individual that really struggled meeting that criteria. They were not able to meet the 3-hour criteria that her insurance wanted for her to be referred for rehab. But worked with the hospital because one of the problems was that the hospital would basically come by, the therapist in the hospital would come by, and if she was sleeping, they would just mark her as unable to participate in rehab. And or if she became tired after 30 minutes, they would mark that. So worked with the hospital on getting them to break it up and to do more frequent visits, to offer her rehab more often, and to break it up to where she would have rehab in smaller sections that she was able to tolerate, in order just for the short term. You know, sometimes it's hard working with hospital rehab as to how busy they are and stuff, but in the short term, to really show that she could access if it was given in a way that could tolerate her fatigue and tolerate her energy levels. So then was able to do that and to transition her to inpatient rehab.
Okay, Gunjan, I'm putting you on the spot for this one. Can you read Dr. Jurvich's comment?
Dr. Jurvich says medication review to get rid of cholinergics and benzodiazepines. And he also says sleepiness in acute care setting may have been hypoactive delirium that was missed by the clinical team.
Yeah. And all of those really important factors. And I will say this individual was accessing care in one of our more rural hospitals. So I think that the ability to be accessing providers that really have understanding of older adults and trauma don't have as wide of that. So I think it was also beneficial for her to then get into an inpatient rehabilitation that had more experience and background in older adults and trauma.
I just want to add a comment. I don't have a question. That I've heard Dr. Jervis talk about age-friendly healthcare, and he always says the forums should be performed as a set. And we have these echo sessions each month focusing on one of the forums. But with this presentation today, I think this was a classical example of how and why all the forums should be performed as a set. We saw medication review, we saw mobility assessments, we saw mentation. So this was great. Dr. Jervich also has another comment. Need to use confusion assessment method, CAM, as a tool to evaluate patients in the acute care settings.
Yeah, I think I know as I move forward with developing, you know, older adult trauma response and what to watch for with blood thinners and things, I'll definitely involve you, Dr. Jurvich, in that, developing those materials.
Okay. Oh, and then there's another. Oh, Sanford has switched to NUDESC for delirium assessment in the medical surgical areas. And Dr. Jurvich has another comment here that, of course, I can't read.
Hypertonicity of muscles could be CNS trauma or medication side effect or both.
I have no idea what is happening with my vocabulary today. I apologize. I feel silly.
It's okay.
Okay. Does anybody else have any questions, comments, anything else for Rebecca or anybody else on the call? Question, was the patient discharged to home, Rebecca?
The patient, after an acute inpatient rehabilitation stay, was discharged to home with home health care. and accessing, I believe, just PT and speech in community.
In response to Dawn's comment about delirium assessment, Dr. Jervich says Sanford Fargo has delirium assessment cards to attach to ID cards.
Oh, perfect.
Yeah, and we'll just give everybody maybe another minute to go ahead and put a comment, question in. And in the meantime, I just wanted to go ahead and take the opportunity to remind you all to please, if you haven't already, put your name and facility and email in the chat. Be sure to complete the post-test and the evaluation. If you are looking for social work credits, please be sure to do the evaluation. That is the main requirement to receive those credits. And if you could also turn in the roster that was attached to the email that I sent out. It's just kind of another way to cross-check to make sure we've got everybody covered. And Dr. Jervich does say best practice is to screen every 8 hours for delirium in the hospital and maybe the nursing home setting with COVID.
So, and then I'll just say, so we are, so Lynn McGarry asked, random question, is there any research coming available in regard to COVID and brain injury? Yeah, and I'll call out Lynn, who knows a lot about brain injury because Lynn's one of my former interns. But yes, there actually is quite a bit around COVID and brain injury. And it's just now really starting to be addressed, is the cognitive effects around COVID, and really a lack of understanding. Is it really, you know, COVID does seem to have some multi-systems impact. The brain being one of those systems is also impacted by it, but also the hypoxic effects. You know, one of the things that we know about COVID is that individuals can really become hypoxic without having that kind of awareness. And, you know, anytime that you're having that oxygen deprivation periods, even low level oxygen can impact cognition. And then there is, you know, longstanding has been known, you know, there is something called ventilator brain, where particularly for individuals that have been on ventilators for a long time, even if they haven't had any trauma to their brain, can have cognitive impacts from being on those ventilators. And so particularly for those individuals that individuals, so Carol says patients of all ages with history of TBI seem to have more and worse neurological symptoms and much slower return to baseline levels. I would say yes. Dr. Jervich says that they're gearing up for a post-COVID syndrome in older adults as related to inflammation, muscle, and brain function. So yeah, it definitely is a big issue that's on the horizon. So piece of that. So, and I will say, you know, we are the Brain Injury Network. We are part of the School of Medicine and Health Sciences, funded by the Department of Human Services. And so we provide brain injury education, awareness, and support across the state. So if you ever are working with an individual that has sustained a brain injury, or family members, feel free to refer them to us. If you yourself as a professional have questions, would like follow-up, please feel free to reach out. We do have quite a bit of educational opportunities as well. So we do have some online free modules. We have a brain injury basics class coming up. We have a certified brain injury specialist training. And we do every other week webinar Wednesdays around different topics around brain injury. So feel free to definitely reach out. We always can also do customized training if you do work at a facility or with a group of providers that would like some additional training on working with your population.
Rebecca, would you like me to put the link to the TBI page on the Center for Rural Health's website?
Sure. And then Carly Enders, who is our outreach coordinator for the Brain Injury Network, just did put a link in the chat on our upcoming events.
And just for everybody else, I also put the links to the post-test and the eval in the chat as well. And I don't see any other comments coming through at this point. So I think we could, unless Rebecca, you have anything else, we could maybe give people 10 minutes of their day back.
No, it sounds great.
Okay, all right, thank you. And thank you for bearing with me while I don't know how to read. But thank you everyone for attending. Please feel free to reach out to me if you have any questions or concerns.
Thank you. Thank you,
Thank
everybody.
you, Rebecca.